So hello everyone, this side Dr. Hira, and this session was planned and we discussed that in the beginning of session I will discuss with you people planner. So let's start without delay, and I am hopeful all will be fine. Say me hi in chat box. Sarish, Taiba, Amir, Hira, Dr. Asra Arjuman. So I am hopeful you all will be fine. And let's start without delay. So this is the first slide. Apology for if you are feeling kind of rush, because I won't give, I will not take much time. The main cases will be taken by Dr. Saba. Dr. Saba, are you here?
Yes, Doctor.
Are they? Okay, that's good. Challenge. So, as you people know, there are 14 modules for MRCPI OSCE, and few modules are big and few modules are short. So, but we have decided important modules and the bigger ones we will take in 2 sessions, and the short modules and comparatively less important, anything can come in exam, but comparatively less important, we will take those modules in 1 session. So early pregnancy is important, though it's short module as compared to other, but we will take it in 2 sessions, right? Maternal medicine, this is a giant module, one of the giant module with labor and antenatal. So we will take all these 3 modules in 2 sessions. We have divided antenatal module in 2 parts. One part is fetal infection, one part is antenatal care, right? Fetal infections, if we are dividing it, so we will take it in 1 session and will become short in that way. Labor delivery, very important module, we will take it in 2 sessions. OBS emergencies with postpartum, we will cover this module in 1 session. Subfertility short module, we will cover it 1 or 2 sessions depending on actually your feedback. General gynae in 2 sessions, urogynae in 1 session. Surgical and post-operative complications. This is actually, they are actually 2 modules together, but they are short. So we will try to compile the recalls and the regular routine stations in 1 session, but we can modify. We will take it in 2 sessions as well. Oncology, we have divided in 2 parts, pre-malignant conditions and malignant conditions, and we will complete it in 3 parts together. Contraception short module, we will complete it in 1 session, and clinical governance, ethics and audit, we will complete it in 1 session. So probably roughly it will be 24 sessions course. So this is actually a tentative planner which we want to cover in your comprehensive course. So how we will cover each module? So you must have heard people are courses are, or organization or companies are launching their courses in 2 ways. In first course, they cover only routine stations, and so that you can actually have understanding how any topic can come from that module. And the main course, they take it in the end, near your exam, when majority of candidates book their exam and have confirmed sort of confirmation, we believe, we know that sometime it can be as late as 1 week before your exam. So usually they plan their fast track or crash courses, which is actually compilation of recalls near the exam, and this is the main thing. But we believe that when you start your preparation, you should start from very targeted way. You should do recalls first. So we are changing the history of MRCPI courses. Every organization, every company will teach you routine cases, and then they will launch a separate course which you have to subscribe separately near exam when you are already in a stress. So here you will feel the difference. We will actually cover your recalls first, and these recalls will be module wise. And if we will think recalls are less and topics are more, and the probability of coming actually exam stations from that topic is high, we will cover them. And we will create standard stations so that you can have idea. So how is that? How is that way? Arjuman, Amber, Hira, Taiba?
Yes, ma'am. It's okay.
Okay. So this is the way we will complete our course. We will be very organized. We will cover every module first recall wise, right? And leftover topics which are not covered in recall, then via making standard stations on them. So you don't have to do separately recalls, and you don't have to cover separately paper wise. You know, doing paper wise when one station is coming from oncology, one is coming from general gynae, one is coming from actually maternal medicine. So if you are doing the paper wise, you are not organized, you are not actually satisfied that you have complete anything. So if you are following that way, which is very organized, you will be satisfied and you will learn a lot. So together, actually conducting these 24 sessions, you will not have, you will not require anything additional to complete, and you will not be forced to join any other course. So this course will be whole. That's why very thoughtfully we have decided the name comprehensive MRCPI OSCE preparation, right? And the aim is Fab 2026 attempt. So just for example, this is your early pregnancy module. So our targeted sessions will revolve around the recalls, and we have compiled them. See, like in Fab 2025, 225, November 22, we have seen ectopic pregnancies coming again and again as SPT and SD. So we will cover that station first. So you will cover ectopic pregnancy via SPT and SD, right? And we have noticed that miscarriage and early pregnancy loss like scenarios are being asked in 2025 Fab May and Fab 2025 two times recently via long cases and SPT. So we will cover miscarriage, right, as a topic, and we will make scenarios which are actually your exam scenarios. You're getting no more point, Arjuman? Arjuman. Hira. Where are your biases, guys?
Okay.
Okay. And then the molar actually came as SD, breaking the bad news, which we say BBN in November, hyper MSCs in as SD, OHSS in actually November as long case, and also tested many times as SD as well, ovarian ectopic as SD, PUL as SD, right? So these are actually your recalls. MRCPI has tested your knowledge via these topics like ectopic, miscarriage, molar, nausea, vomiting, ovarian ectopic, which is non-tubal ectopic, and PUL. But still, you will see recurrent pregnancy losses is not covered. So we can't leave that topic. If we will do paper wise, we can skip many topics. They can come in exam. And by the way, in 2025, in your recent exam, you have seen a lot of new guidelines, right? Your miscarriage, ectopic. In 2024, it was updated. And similarly, recurrent miscarriages is a new addition. So we can't skip actually these important guidelines. So we will cover these guidelines as well. And as there are no recalls for these topics, so we name these topics as routine stations, so that we can say that you have actually prepared fully. You have completed your syllabus, right? So we will actually pick those topics which are not tested in recalls, but they can come. And these are these recurrent ectopic, recurrent miscarriages. Molar has come many times, but gestational neoplasia never came, so it can come, right? Miscarriages has actually come, recurrent miscarriages and septic has not come, so we will cover it via creating scenarios. And similarly, very exciting topic which I have seen, MRCOG 3 exams favored, but I want that you people to actually have command how to actually do SPT with a teenage girl who want termination. And it my gut feeling it can come in exam as well. A lot of things which you know about as SPT at this topic. So these are those actually topics which are not covered in recalls, never came as recall in previous papers, but they can come. So we will cover them as well. So you will do early pregnancy in 2 sessions, right? And in 4 telegram sessions, and you know everything about early pregnancy. You will not skip any recall, and you will not skip any possible station. So this is actually a formal introduction about our comprehensive course. Any query now about planner and about actually agenda? Hira? Asra?
No, doctor. Thank you so much.
Trust me, this is the first session in my life which I have spoken in English. And I'm amazed. How was this actually? I know I did a lot of blunder in grammars.
Anything, it was perfect. You know, it's not a language test actually. They are testing like us clinically. It's not a language test. So speak whatever comes.
So Saba told me that you can do, Dr. Hira, you can speak while you are working. So see, it was not that perfect, but I will take your SD sessions and I will try to actually follow the exam language, which is only English. So Saba told me that keep the course in exam mode, and we will actually teach you in only in English. No worries. Where needed to explain the complex topics, then I will be actually explaining in the language which you understand most, right? So Saba, onwards now. This
Okay,
is your task.
Thank you, Dr. Hira. Okay, so to summarize what Dr. Hira explained, we will cover all the modules. There are 2 ways to cover the modules rather than being going recalls year wise. We will feel like we are hopping year 2022, then 23, 24. And but what we decided, we will cover module wise, like early pregnancy. We will do all the recalls of early pregnancy, then potential recalls, like which can come, not came yet. So this way, whenever you go to the next module like maternal medicine, you know that I have covered early pregnancy in all aspects. So I'm ready for that module. Inshallah, this way we will cover it. So let's start today. Who is my volunteer?
Dr.
I need a
Hira,
volunteer.
Dr. Hira Amir, ready?
I'm saying if you have like the volunteer for the long case, maybe we can start with the long case first.
No. We want to start from you. We
You
don't
want to
have
start?
long case volunteer. No worries, Hira. I believe you will learn a lot. This is not that exam which you have to give your final things. You are just learning. We believe you will commit so many mistakes, and we are here to actually support you. No worries.
Hira is already prepared, Dr. Hira. I know her. She is already prepared. Hira?
Sorry, yeah.
It's
So what
very,
am I doing?
yeah,
Is
very
it
easy.
smaller or ectopic?
It's ectopic.
Okay. All right, it's an SPT. So can
Yes.
I see the case?
Read the scenario.
Yeah. I cannot see the screen. Wait one second. Yeah.
The screen is not visible, Hira.
No, it is. Thanks.
Let me know. I will start the timer.
Yeah, start the timer, and I'm reading it now.
Enter in the cubicle.
Hi, my name is Dr. Hiramir, and this is my code.
Read your scenario.
Yeah.
Hira, start your station. You forget the SPT. 2 persons are sitting. One is examiner, one is patient. So start with your patient.
Okay. I'm Dr. Hira. I will be one of the physicians taking care of you today. May I know your name and age, please?
My name is Linda, and I am 22 years old, doctor.
Okay. Thank you, Linda. So just before we start, I have your report with me, and a brief history of your, a brief short version of your blood test reports as well. So I'm gonna ask you a few questions around your presentation, what you came for in the clinic, and why were these tests done, and what is the plan going forward. All right?
Okay,
And
doctor.
if you have any questions, you can stop and clarify for me, okay?
Okay.
All right. So Linda, I understand you were 8 weeks pregnant
Yes,
and you
doctor.
came with pain and light vaginal bleeding, is that correct?
Yes, doctor.
Okay. How are you feeling now? Is there a lot of bleeding now? Is the same? What about the pain?
Doctor, I have mild pain and the bleeding is minimal, spot only.
All right. Is there any nausea, vomiting at all?
Yes, doctor, sometime it comes, not now.
Okay. And did you feel dizzy at all after
No,
this
doctor.
episode?
No,
Okay.
doctor.
All right. And was this a planned pregnancy?
Yes, doctor.
All right. And did you take any treatments for this pregnancy, or was it a natural conception?
Natural.
Okay. And is this the first episode of bleeding during this time, or since you found you're pregnant, or it has occurred a few times?
Doctor, bleeding came when I went for the scan. It was spotting over there. Now they called me in the clinic. They said, come today. I'm very excited because this is my planned pregnancy and I'm preparing, looking forward to it.
All right, I understand. So let me ask you a few more questions and then I'm going to come to the report of the ultrasound, okay?
Is everything fine, doctor?
Let's see. Let me ask you a few more questions and then I'll be in a better position to answer along with your reports, all right? Do you have you been pregnant before?
Yes, doctor. I have one miscarriage and I had one pregnancy in my tube, left tube, and that was very scary.
And this is your third pregnancy?
Yes, doctor. That's why I'm very excited.
All right, I understand. And how long was the last pregnancy? How long ago?
It was early day. I was fainted and they took me to the hospital. And
how long ago was that?
Oh, you're asking? It's like 1 year back, doctor.
1 year back. And took you to the hospital and then they did the surgery, or did they give you medicine?
They did surgery, doctor. I was unstable and they later on they told your tube is removed. To be honest, I was very upset. They didn't ask my permission.
Oh, I'm sorry about that. So I believe it was the left tube that was removed, right?
Yes.
All right. And okay, and was there any complication during the surgery or after the surgery?
No.
Did they give you the blood? Did they
No.
transfuse blood?
No, doctor.
All right. I'm going to ask you a few questions regarding your any medical conditions that you have.
Doctor, I'm asthmatic.
Yes, but do you take any inhalers or medications?
On and off inhaler, and I'm on regular follow-up.
Okay, great. And apart from this tubal surgery that you had, any surgeries in the past?
One DNC and one tubal removal. That's it.
Okay. And what is your blood group?
O negative, doctor.
Oh, negative. I'll note it in your no. Any allergies to medications?
No, doctor.
And are you on any regular medications apart from your asthma meds?
No, doctor. I just taking folic acid.
Okay, that's good. All right, so thank you for answering all of those questions. So let's get on to your report that I have. So we did an ultrasound, like you said, and there was some bleeding. Now, we were expecting to see the sac of the baby inside the uterus or the womb of what we call as uterus, but unfortunately, we found the sac in the right tube.
What are you saying, doctor?
Yeah,
What can
I know
cause
it can be. I know it can be a little upsetting given your history of tubal removal and the DNC before, and I would completely understand you were expecting.
No, doctor, I don't want to talk to you. Call your senior who removed my tube last time and she said it will be pregnancy inside my womb. No, doctor, it's not acceptable.
All
Not
right.
can
I
possible.
will.
Why it's happening to me? My sister had pregnancy. She has a beautiful baby. What's happening me again and again?
Yeah, that's a fair question, and it can come to your mind, but I'm here to answer your questions. This can happen to anyone, but more likely in the people who have had previous episodes of pregnancy in the tube. And in your case, that has been the case, and there has been a DNC as well. So in patients who have history like that, they can have.
I can't listen. I can't listen. This is too much for me.
I'm so sorry. We can stop. We can always book another appointment. But I think for now, we need to discuss this because we need to plan the management. You need a glass of water?
Yes, please.
Okay, here. Do you want anyone besides you? Did you come alone or you have somebody? I can call in.
I would like to call my partner, but let's finish this.
Okay. Do you want some time before we start again?
No, doctor.
Okay. Listen, we are here for you, and I understand it's a difficult discussion, but but there are ways to get pregnant again and have a healthy baby. Okay, and right now, this the sac and the tube, we need to manage this first because we also did a blood test on you, and the levels are higher than sorry?
You will remove my tube?
We will not remove your tube. I will involve my consultants who will be there for you to discuss first with you what are the options. So let's come to the options now. As your levels are higher, you are having pain, there is bleeding, although you are stable, you're not feeling dizzy or anything like that, but still there is pain and the level of the pregnancy hormone in your blood is more than 5,000. That's the point combined with the pain and bleeding and the finding that we saw in the ultrasound. This is leaning towards
your time up, but you continue. Okay, I'm giving you additional time and I will tell how much additional time you took. Continue.
Okay, so this will so we are leaning towards going to a surgical management. Do you have any idea what are the procedures there? Because you've
Yes, you guys removed my tube last time. I know. I don't want to have an idea again. Can you save my tube? I'll be pregnant again.
Of course. Last time you said it was really bad. You were not stable. They had to open you up. But this time I think it would, we cannot guarantee, but I think what we have, the findings, it seems like we will be able to involve our seniors and we will try our best to save the tube. And that would be our goal. But
can you save the baby?
The baby is not, so in the tube, it is unlike, it's a pregnancy unlike in the womb, okay? Um, However, in the womb, the baby or the sac of the baby gets a good blood supply, it's a thicker tissue, and the baby grows normally. However, in the tube, as you can imagine, there is no muscle, no blood supply, no placenta. Placenta is an organ that's a nutritional organ that the baby is connected to and that forms in the sac, gives nutrition to the baby, is not available or doesn't grow in the tube. So this is not a normal pregnancy. Okay, so we have to remove this, and after removal, we will try to save your tube. And if, God forbid, we are not able to save the tube, the life of you, the mother, is most important.
Doctor,
If we
I want baby.
Yes, of course, we will have a baby. There are so many options with advancements in science and technology that even, God forbid, I'm not saying you will, even we have seen patients who have lost their birth tubes or their tubes are blocked by infection or other causes. They can still conceive by a method called in vitro fertilization, which is artificial technique to get pregnant. And it is a very common procedure being performed.
I came
And
here to see my baby heartbeat, and you are telling me an artificial way to get pregnant. I can't get this.
it's an artificial way in a sense that
Can I go to any other doctor? Is it fine?
yes,
if
of course.
you give me my report?
Yes, of course, you can go to any other doctor, and we will discuss the fertility treatment in the next, and we will send you to the specialist in case you decide to, get treated here. Okay, the fertility specialists will explain you, but I was giving an overview of what is going to happen if things go in the wrong direction. However, do you have any other questions in mind? I'm
Doctor,
really sorry for what happened. I'm really, really sorry. And I'm there with you. I will call my seniors as you said you want to see them.
happens with me, or it can happen with anyone, like any other patient you saw with this and getting pregnant again?
Of course, there are so many. So having an ectopic pregnancy does not mean that you will not get pregnant again. You will get pregnant again, but unfortunately, the chances of getting pregnant in the tube becomes higher than the normal population, than the people who are having pregnancy in the womb.
Doctor, I hear there is an injection. Why you don't give me that? My friend had that.
We don't give you that. So yes, like I said, you have pain. Your levels in the blood are higher.
That
And
much
then
pain, doctor. It's very mild pain.
It's very mild pain. Yeah, but the size of the sac, baby sac that we're seeing is more than the cutoff, and also the levels are more than the cutoff. But obviously, if you want to try the injection, we can explain to you the risks.
I'm gonna stop you because it's 15 minutes, so I can't give you the double time actually.
Oh my God, you were being so difficult with me. But
Because
it's okay.
you didn't give me warning shots, you didn't involve my partner, you
I did involve your partner.
later when I said I'm
Yeah,
gonna
because when you started crying, you
yeah,
emphasized before.
you made me the
Okay.
limit to cry. I had to
Okay.
cry in front of you to get your attention for BBN. Please break it. I see.
Okay.
And the other thing, Hira.
Hmm.
Okay, let's coming to your mistakes. I'm gonna tell your mistakes, then I'll perform the station.
Sure. Yeah.
So you didn't ask, can I call you Linda? Because like
Because listen, Dr.
Dr.
Saba,
Saba,
Dr.
Dr. Saba, sorry to interrupt. Can we give her plus points first so she will feel good, and then we will slowly add.
नहीं it's fine. I'm very thick-skinned. It's okay. मैंने बड़ी OSCEs दी हैं, बड़े feedbacks हैं. No problem. Go ahead, Dr. Saba. But thank you, Dr. Hira.
actually, Dr. Hira, I wrote in this way the part she skipped, and I'm coming to plus points as well because I wrote it in the start.
It's okay, it's okay, it's okay, it's
When
okay. Go
our
ahead.
patient introduce, ask her the permission, like which name she would like to call. This is
Okay.
like the part of ethics in the Ireland and all over the world. Okay.
Okay, sure.
Then,
Yeah.
Hira, you should be vigilant. Like you already had the report with you. You know it's ectopic pregnancy, so you should be like warning shots should be in your mind, and you should be like you have to be empathetically approaching. I can see that you are here. Okay, Linda, I can see that you are here with your reports and some blood tests, and you're 8 week pregnant. I have to discuss this report with you, but before going to this report, like you said, I want to know you better to ask certain few questions. Is that fine with you? Okay, you got my permission. That was fine. Then again, that was perfect. You started with the first trimester. You asked my planned spontaneous pregnancy. It would be better if you can ask me how you confirmed it with the urine test or the blood test. It would be better because he had tubal pregnancy. Later, she had a pregnancy, so she was told earlier to check this. You asked about the You didn't ask about the folic acid, I guess. I circle it. Then here, when I was telling you, you said, "All right, I understand." I don't think so. Yeah, when I asked you, everything is fine because I was anxious. I was the patient who had the bad history before, and I was told to do the early scan. So there was something in my mind. So when I asked, everything is fine, you said, "Let's see." Don't say this patient. Say whenever she's on everything fine, you can ask her wish. You want me to discuss your report first, or you want me to ask certain few questions so that I can discuss the report in a better way to give you a better management plan? Is that fine, Linda? Please. I can understand. Do you are anxious about it? I can understand. So this way the patient gives you permission. Whenever patient interest, here you breach her autonomy. She was trying to jump on the report. It was fine. You can carry in both ways. You can carry in both ways. First, you can tell her the report, do the BBN, offer her wife to involve her partner, tell her this has happened. Then you can ask the detailed history later on. So I was being a difficult patient because I have to cover both aspects. Sometimes patient interrupt, sometimes they don't interrupt. But the one like this, they interrupt usually. So don't say let's see. Okay.
Okay.
Ask,
So what should I
ask
say then? So
you
what should
say,
I?
Linda, I know that you are here to know the result about your report. So there are two options. First, I can discuss the report with you. Other way is that if you allow me, I can ask certain more questions to know you better so that we can decide your management and treatment in a better way. I will be able to help you in a better way. Now I will be in a better position. Is that fine with you? Like you can say anything which makes me feel like okay, you are doing it for my concern, out of concern. You are not just ticking or tick mark your questions. You got me, Hira?
Yeah, yeah, yeah.
Okay. Like with the patient permission, if she interrupts you, ask her, you want to know the report first or you want to go to the question part? Because she is simulated patient, she will do in either way. She will take you to that.
Uh-huh,
Okay,
okay.
when I told you, you asked my obstetrical history, that was beautiful. I told you about my left tube.
I said
The,
sorry.
sorry?
I said sorry.
Yeah, I'm sorry about that. That was a beautiful point. I give a star over this. You know, I marked a star
Mm.
for this. And then, sorry, coming toward the first trimester, you didn't ask with the bleeding passage of clots. You ask about nausea vomiting, ask about the passage of clots because here you distinguish between the ectopic and the molar. The now obstetrical history you asked about my tube, and here I was excited. I told you that I had a miscarriage. Now I am excited. So here again you should be like your ear should be ringing. She's excited. She gonna make trouble for me. So this again I circled it. Whenever patient become excited and you have a miscarriage, ectopic or molar, you have a bad report or you have anomaly report for that patient, please, her BBN should be addressed in a better way. You ask, involve her partner, everyone, whatever she wants, ask in the beginning. Respect that patient because again, Hira, you did, let's go to the part. Now, then you said I'm gonna ask certain few questions. Like you were asking questions again, but I didn't interrupt you. You asked I'm gonna ask few questions. Like here you again said this line. There was not needed. I was systematic. You addressed that. You didn't ask my family history. If you have been asking, I should told you my sister had the recurrent ectopy or infertility treatment runs in my family. Again, you didn't skip. You skipped this. Gynecological history you asked, but you forget to about the STIs or partner's history or I'm in a stable relationship or not. That if you ask that, maybe I
Because
said
I
that.
already, I already got a risk factor. There was a DNC, there was left tube, so likely we
Yeah,
can
maybe
look for that.
STI. If you ask me, I can tell you like I was
But
chlamydia. I was treated for chlamydia.
but
Maybe
do-
like
but so in SPT we don't have that much time to go into that much
one liner,
detail.
one liner, one liner. You
Okay.
can ask me. Do you pardon me? Do you have any sexually shared infection? Please, this won't take any
Mm-hmm.
time, Hira. I'll perform this. I'll perform this in 10 minutes. I'll finish this session in 8 minutes. Okay, give me time. Then
Mm-hmm.
you asked surgical history. That was beautiful. O negative. You when I told you O negative, any reservation for blood transfusion should be asked. Then you didn't ask my alcohol or smoking history. You skipped that. BMI, of course, you forget to ask. Then. Okay, history was done here. For a topic for early pregnancy, for these type of things, please ask her sexually shared infection in gynecological history, and whenever the spotting, ask the passage of clots. These two things were the main. Otherwise I can ignore the family history and other history as well, but you need to touch
So
in.
for the clots, I think I asked about the bleeding, and then you
That's
said
perfect.
it's
That's perfect.
mild bleeding. So then
Okay,
I
that's
wrote it.
perfect. But the passage of clots, examiner want to listen in front,
No, okay,
want to listen
got
because
it.
like the molar and all that. So early
Yeah, yeah,
pregnancy
yeah.
is designed in this
Mm-hmm.
way. They have this line in their key. I have seen the
I see.
examiner key. They have this line. In fact, sexually shared infection line is also is in their key.
Uh-huh. Okay,
Okay.
thanks.
So
Mm.
we will not re yeah. When I said can I get pregnant again? Here you said me we will not reassure something you said I forgot your answer, but I comment over it reassure and I marked the question over it. And when I said can you save my baby? Here I was trying to drag you towards the drawing. If you can draw the womb, the tube, there's no need for the muscle, blood, bone, placenta story. If
Ah,
you draw
really?
the structure of
Oh,
the tube
draw.
and the womb, you can see the space is small. There's no heartbeat in the baby. When I ask the baby can survive, you can
Mm-hmm.
say, I can't see any heartbeat. The baby is not alive. Unfortunate.
I over-explained.
Draw the tube, then draw the tube and say, because this part is very small, usually the baby don't implant in here. This is the abnormal side. Only the womb is the right side. That's it.
Mm-hmm.
Okay, the patient
Yeah.
is not like they are not interested in the blood bone and these type of things. Okay,
Mm.
last way when I was like you by the way, important point, you didn't ask my mental history because when the patient is suffering from the miscarriage and the ectopic pregnancy, usually they
But
have mild depression or
she
something.
didn't know that she had a miscarriage, did she?
She didn't know she had ectopic because she is excited, but she had a miscarriage and her tube was removed and she was anxious to embark into the pregnancy again and she was told she has to come early.
Mm.
This was a
Okay,
pressure on her head. I'm saying
okay,
your patient was fine, but please ask mental history.
okay. Mm-hmm.
Please don't skip these type of things. In the last session already, I did suicide when I went home. Please
Yeah.
don't make me suicide again. Ask about the mental history, and here you need to connect me with the sport group, with the groups who had been gone through this. You have said then when you was telling the IVF option, that was beautiful part, but you should say that we will involve the fertility specialist. You involve later,
Mm.
but the one liner should be like this: we will involve the fertility specialist. I will give you the
Mm-hmm.
more information leaflets. There are certain artificial ways in which we don't need the tube. You tell her the tube is just the passage of the egg. Its part is like you're perfectly fine. You have the womb, you have the eggs, you can be pregnant again. But we should intervene with the artificial way IVF. Okay?
Yeah.
If he asks, then tell detail, otherwise don't tell detail. Give her leaflets, connect her to the support group. Here, your consultant, when she was angry, she was call that consultant, call that consultant. He asked me, you will be pregnant. Here, tell her the ratio of rate, like when after self-injectomy, how much is the chance of having intrauterine pregnancy. Tell her the risk factor, tell her about the adherence. If she showed her sexually shared infection, tell her this way the all these things can be sticky inside. Okay, the transfer of egg can be transferred. So you should defend your consultant as well. And you told me like the chance are more, but again the chance due to surgeries were more. So you guys did surgery on me. And she was again upset they did surgery without my permission. You can say one liner because of the saving life. Okay, you said that. And again at the end, beautifully, you said your life is more important. You are more important. You can have baby. That was fantastic. So the things I am telling you, these are not mistakes, Hira. You can cover this station in your style, but I am coming what examiner wants to listen from this.
Yeah.
Now I will start my timing and we will do this. Okay, these were my questions. What does ectopic pregnancy mean? Here you should make a drawing. Okay, let's solve this station. Let me start the time. I'll be honest. Now you be my patient, okay? You want me to do this, guys? You want me to do this station, or you want me to just give feedback and I will tell you the ideal key?
I think don't do the case again. I think so.
Yeah, it will take more time, 10 minutes more, so fine.
Yeah.
Okay.
Yeah.
Okay, so here, Hira, okay, we will go through this. Here you should be, this is very beautiful question. What do you already understand about the scan? Maybe I know it's a topic. If you ask me, I can be play in any role. I can hear that I know about my topic, or I know they said me there is abnormality. Okay, so always ask whenever you have report. Always ask her perception. Then would you like me to explain the scan shows? Okay, here she goes to the scan, but you have to go to the history. This line, I'm sorry, the scan shows the pregnancy is not in the womb, but in the tube that carries the egg. Here you should draw. Again, if she asks what does ectopic pregnancy means, you need to draw. You tell the pregnancy that is not normal inside the womb. It's in the tube that carries the egg. Baby alive or it can be moved to the womb. Here you should address her concern that baby is not alive and cannot be transferred into the womb because its growth tissues or the food passage or anything like placenta or after birth. We say placenta is after birth. That has already implanted, so we cannot transfer it. Did I do something wrong? Here she need reassurance. Maybe she has like a pressure because of her previous history. So it's not in your fault. It's not in your hand. Like try to be calm down her. Can I go away on its own? No, the tube will be ruptured. Last history, you remind her. What did I didn't finish the most question because I was like looking for, I cried, I take your time. So I didn't ask more questions from you. What treatments are available? You can tell her there are 3 ways, like wait and watch, there are injections, and then surgery. But in your case, we will do surgery. Please, enumerate, just quick enumerate 3 methods. Because I came again and I asked you, is there any way of injection? Methotrexate should be addressed in these cases.
Yeah, because I knew that my time is running out.
Yeah.
So I just
I have a
gave
question. Dr. Saba, I have a question. Actually, in this case, can we go for self-angiotropy as in the RCOG guideline?
That was the treatment.
Yes.
Hira, if I had been okay, let me do this. If I had started this patient, I can make this picture and I can tell her she don't have this tube, right? She don't have one tube. So I can tell her here the baby, okay, guys, don't draw the baby. The patient mind, when you cut this tube, the patient cries, oh, you cut my baby, you cut this. Patient do this. So don't draw the baby, you just make a spot. In your case, the baby is implanted here. Normally it should be here. You see this site is small. This is abnormal site. Like once it happened with the last time we removed your tube. and I'm sorry about that, like whatever. So you tell her this part can be ruptured. It cannot expand when the baby size grows. But her baby is not alive. Okay. If there is FCA positive, then you can tell her it cannot grow here. It can expand, ultimately rupture the tube. It will harm your body. It will harm you. It can be dangerous for you. So treatment option, you just enumerate: conservative, medical, and surgical. I'll be able to get pregnant again. You tell her the chances become low each time we have a topic. The chances are running down, but of course you can get pregnant in the right way. Here, guys, Hira, you should again already involve the fertility specialist for her, because she has a problem. She has a already problem. We don't let her to get pregnant again and again by herself. She already had one miscarriage, one ectopic here again, ectopic again, a surgery. Fertility specialist, fertility counselor should be connected over here. Do I need injection for my blood group? I told you O negative. You skip that part. But again, when I asked you, you can say that after the surgery, we will give you. Okay, the other thing, guys, are you making the page like this? Here, the risk factor. Because I have make a page like this. I have wrote here O negative. No. Before that, I have written a miscarriage, and then I have written the tubal removal, self-injectomy, O negative. These things I have written here. So when you address, and asthmatic as well. If you had do my methotrexate, then you have to address my asthma as well. So these 4 things I have written here. When you do the management part, look in these risk factors. No risk factor should be left unaddressed. You have to look into this. So if I ask, do I need injection for my blood group? You can tell me that for future baby protection, we have to give, because your blood group is O negative. What is the blood group of your partner? This we ask in the long case usually. Here you just give her the injection. What follow-up is needed? So here follow-up was, guys, I have, okay, let's crack in this way. Linda, I can say it's a difficult time for you. You see, there is we have this tube, this is womb. In your case, unfortunately, the baby is again implanted in the tube rather than in the womb. I'm sorry. Before that, you already asked her, you want to involve something. Can you call your partner? You want someone to come inside, because I have a difficult news for you. The results are not what we expected. Unfortunately, it's again implanted in the tube. Patient cry, give her pause, offer wipes and tissue. You want me to stop, or you want me to continue? You want me to continue, please? Okay, now she will, if you want to continue, she will ask what I done wrong. It was not in your hand. Can I go it away? Or so? No, it will be ruptured. It will harm your life. What treatments are available? We have the three treatment options. You tell again, one liner. I'll be able to get pregnant again. Listen, we will try not to cut down and remove your tube, but we will make a hole to take out this abnormal pregnancy out of your tube. We will try to save the tube. Special consultant will be involved. We try to save the tubes when one tube is removed. This was the key. Examiner want to listen this. We try to save the tube. We call it self-injotomy when one tube is removed. So in your case, you already have one tube, so we will try to save the tube. The one asked the question that was very beautiful from the candidates. Do I need an injection? Yes, of course. You have O negative blood group. What follow-up is needed after the surgery? 1 weekly, we will do your blood pregnancy test. We will do the 1 weekly till it becomes negative. Last time, she can say like last time you did after 3 weeks. Yeah, because we removed the tube, then self-injectomy, 3 weeks, and self-injectomy 1 weekly till it's negative. This was the follow-up. What warning signs should I look out for? This patient won't ask. This was a safety point here. Patient won't ask this question. You should tell her. Right now, if you say, okay, you finish the case, you tell her the treatment option, give information leaflet, give her IVF or a specialist appointment, and tell her is anything left, anything you want to ask. She say, okay, I want to go home and I want to discuss with my partner. Here you tell her the safety point. Before you go, Linda, before you discuss with your partner, I would like to tell the certain signs. If you ever feel dizziness, you feel not being yourself, there will be syncope or anything comes, bleeding becomes heavier, or severe pain comes in your way, please contact us. This is like emergency. I'm giving you 24/7 contact number. So here you have to either, it's a way between saving the life and respecting her autonomy, like respect her autonomy. If you want, what is your plan? You want her to get admit. If she's fine, ectopic, pain, bleeding, of course, Hira picked the station very beautifully. The station was for surgery, not for methotrexate, but you have to check for her. Can she get into the clinic today, or she want to go home? If she want to go home, then tell her the red flag signs. You all know these red flag signs. Dr. Hira, my slide is not moving. Okay, it's moving. Let me erase these things. Any question, guys? Here is all the answers written. Can I have normal pregnancy? Most women go and have a healthy pregnancy. We'll scan early next time. This can say if the patient don't have ectopic, but I changed your case from the key. I made it difficult. Trust me, I made it difficult. The case will be simple. Patient won't be having the previous tube, but as we in the slides we put an easy case, so I wanted to check like a difficult case. Hira, I'm sorry I'm doing this with you.
No. I'm okay. Don't worry.
Okay, here you tell
Saba?
one-liner.
Dr. Saba,
Ji,
if
Dr. Hira.
patient is actually having multiple risk factors for recurrent ectopic pregnancy, like one previous episode, this time again having some STI, let's say gonorrhea or chlamydia, and also smoker and obese, and so if and these all these risk factors will make her high risk. So if she insists, what is the best plan for me, and she want next pregnancy as well, so what we will offer, salpingectomy or salpingostomy?
Dr. Hira, here again, we in the SPT, like if you're asking for the long case, then I can counsel my patient for salpingectomy and going toward the IVF with involvement of the fertility specialist and my consultant. But here in the SPT, if this, it does come in this way. By the way, I made it halwa and a difficult case. But if this case come, I will do the salpingostomy, because they are testing here. Here I didn't put the much risk factor, like you told so many risk factor, but here the case is salpingectomy, because the examiner wants to know if one patient has a salpingectomy, we are trying to save her tube usually, because
Okay,
the
got it.
salpingectomy patient will come in the emergency and they are like the last resort, like, and if she has no risk factor or she's fine, then we can do the salpingectomy. So examiner wants to listen the difference between salpingectomy and salpingotomy patient. What you are asking, that's a high-end question. That can be in a long
No,
case.
Dr. Saba, actually, what if the same topic comes in long case? So in my opinion, if examiner is giving me risk factors and which make her high risk, probably she will be testing me of salpingectomy or salpingotomy. Then I will give her my opinion. The most safe thing in that case will be the salpingectomy.
Yeah, bilateral removal of the tubes and coming towards the
Because
IVF,
she will
right?
again have, and she's having actually one episode of recurrent ectopic pregnancy and now having high risk factors as well. So all these things will make her more prone for another ectopic, and it can rupture and cost her life as well.
Yes,
So
because this sorry to interrupt, Dr. Hira, I agree with this, but this case, these lines or this management need to discuss in a long way, or it can take like 2, 3, 4, 5 minutes. It can have a viva on this. So
for
this
SPT you did wonderful. If for SPT
it,
you did wonderful.
yeah,
I'm
this
just
is in the long case, it
like,
will come. I
long
agree
case.
with you. So
Okay.
there I have to defend myself. I will ask for the salpingotomy. I will tell her there is a chance for getting pregnant again. But since you already went through so much trauma for the miscarriage, again ectopic surgery, then again third ectopic surgery. So with the involvement of my consultant, fertility specialist, with the involvement of those people, we can offer you removal of, if you agree, we can offer you removal of the tube and then going towards the IVF again. So I can put in either ways for long case. The long case, the examiner say you can give any answer. until you have to justify that answer, what you are saying that. So in NTD, injection was there, ultrasound 6 weeks in the next pregnant to confirm the location. These points were in her follow-up. Safety points, red flag signs, you have to tell the patient after her, like counseling services, bereavement, support groups, information leaflets, here connect her with the counselor. So this again, communication and empathy points you always have with the practice. Avoid medical terminologies. Hira didn't use any, that was perfect. Okay. Here, if it has been a structured discussion, guys, if it has been a structured discussion, then criteria for methotrexate, you should know. Why not expectant management in this case? Because Hira answered beautifully. Your pregnancy hormone is high and the cut size is more than we planned for the injection. Indication for the surgeries, what are those? NTD requirement was here and future pregnancy advice. Early scan 6 week and recurrence rate is 10 to 27%. This is for first pregnancy. Later on, it can like enhance more. So this is like a point where we have to listen, react whenever patient cries, whenever she interrupts you, whenever she wants to do something different, you have to respond her. Start with open-ended question. What you know about your pregnancy, what you know about your details, what you know about your scan. Ask from that. She will ask the question in SPT. Patient has the leaflet, so explain her in a short way and let her ask her questions. You smoking, alcohol, drug, you can remember with this mnemonics. Then red flag sign should be addressed, psychological support, autonomy. Sometimes she says, I want treatment right now. Sometimes she says, I can go back to home or not. So you should answer, she can go back if her home is near, but tell her red flag sign. Emotions are usually have to address in the breaking bad news, and again the contraception advice. If you do the surgery, that can be detailed but not was here. Then referral and information leaflets. This is very beautiful slide, guys. All the early pregnancy
Dr.
modules should
Saba,
be solved with these slides.
Dr. Saba, I have one question here in the
Yeah.
treatment. When the patient asked me that why can't I want the injections. So if
Yes,
she
yes.
insists on like not surgery and injections, so I think I said that I wanted to explain the risk factors. That I mean, we can discuss the options, but there will be risks. Do we go on that or do we stick to the surgery only?
Hira,
Where the patient is saying that, no, I want to try.
I agree. You should, for you, this option is not recommended because of the size of the cyst, the size of ectopic pregnancy is more, the pregnancy hormones is more. It won't work successfully, usually. But if you really insist, I can give you information on that. You want to know that? If you really want to know that,
Okay.
so that's in the key. If you want to know about the methotrexate, she will say, yes, please tell me details. How much the dose,
Okay.
when you will give me the injection, what are the precautions. If the examiner has this question, or like examiner is your patient right now, the patient is the examiner. If she has questions, she will take you to the door.
Right.
You have to walk through whatever patient takes you. What I am doing, I am being like a difficult patient. I'm testing every point.
No, that's why I'm asking you. Like when we have a plan.
Go with the patient. But tell her it's not recommended. It's not safe. It's not recommended. It won't work. For you, this treatment is recommended. You are a doctor. You have to tell your patient, okay? Ectopic pregnancy, you say pregnancy outside the womb, fallopian tube that carries the egg. BTHCG, always say pregnancy hormone. Guys, this table should be crammed up. Like these terminologies should be replaced with these things. Internal scan, we don't say expectant management, we say careful monitoring or wait and see. We can say wait and see. Methotrexate is injection that stops the growth of this abnormal pregnancy tissue. Self-injectomy is operation to remove the tube, NTD injection to protect your future pregnancy. remaining pregnancy cells are persistent trophoblast, and pregnancy not yet visible on scan is pregnancy of unknown location. This is very beautiful slide. You have to remember this was if the topic pregnancy come in the structured discussion, then you have to tell all these three options: expected management, when if this is less than 1500, size should be known. For the medical, size less than 3 centimeter, ideally less than 3000, but can work between like 3000 to 5000 as well. So if more than 5000, then go for the surgery. Size is more, FCA is positive, you all know that, plus woman's preference. If she has size less than 3 centimeters, say 2.5 centimeter, beta hormone is beta HCG is 1800, but he says I want surgery. So you cannot say recommended expectant. We can say you are the candidate for the wait and see, but if you choose the surgery, we can perform that. Again, tell her the benefits of the surgery, like immediately you remove. It's a safe for expectant. There is always a risk. You have to look for the red flag signs. You have to be on follow-up, like tell the positive and the negative of all these things. So recap for you guys, methotrexate criteria. If the patient asks, we can say red flag signs, you should know. NTD, always remember whenever I say O negative or something, please make your page right on the risk factor. And Hira, do you make your page when you were asking the questions?
Yeah.
Okay, that's perfect. If I choose the methotrexate, if the scenario goes towards the methotrexate, then again you have to tell the pregnancy avoidance for the 3 months and early scan in the next pregnancy. Empathy was there. You did my safe management except for the red flag signs because your time was over. Otherwise, if you can incorporate, that was good, because I was creating a trouble. Maybe listen guys, don't get upset like I came out and I didn't reach towards telling her the self-injotomy and connecting her the sport group. Maybe she has like 4 minutes only for the crying and doctor addressing her cry. Maybe in the examiner key is like this. If the patient is wasting your time, she's crying, she's making you here and there, you should just make your patient happy. Address her wherever she carries you. Here the patient has the question, so you have to follow her questions. It's okay if you didn't finish that. Is it clear?
Yeah, perfect.
Hira, next time I will be like Momo patient for you, okay? Straightforward patient.
No, it's fine. It's nice to do difficult cases.
Yeah, because like for me, I can feel like easy case you can do. So I made you recall difficult. It was a recall, by the way. I made it difficult. Okay, so who is our candidate for the molar pregnancy? Here I will be nice patient. I promise.
May I, doctor?
Anyone, guys? I guess Monia said she will come at 2 p.m., right? Asra, are you okay to take this case?
Yes, doctor.
Okay, Asra.
डॉक्टर सबा वैसे आप बहुत चालाक हैं आपने ना मैंने रिकॉल देख रही थी वहां तो बड़ा सिंपल था आराम से एक टॉपिक की काउंसलिंग की और बस मैनेजमेंट बताई
Let them do the difficult things. जब exam में when they will have the scenario in the exam, they will smile. They will say, "Oh, I can do it."
So I like your trick.
And
Yeah, I
नहीं,
want
Dr.
this
Hira, and then she lets us do it for some extra time. तो वो हम finish कर लेते हैं. मेरे साथ extra ही हो गई थी difficulty ये. लेकिन
No,
it's
no,
fine.
it was really
अच्छा
impressive,
है.
Saba.
because
You
like
actually,
I made it difficult, Hira. That's why I gave you extra time, because I was crying and I was doing all this.
Yeah.
And in the exam, remember, if your patient cries and if she pauses and she takes time, your station should not be so long. Like they already gave you marks before you leave, because they was testing empathy. Maybe empathy carries like 4 marks in that station. Usually it carries 1 mark. The pause and breaking bad news, usually it carries 2 marks. But maybe in your station they put it 4 marks. They can shuffle the key. Okay, the molar pregnancy, I won't be like manipulate my candidate. I will do like this.
So Dr.
Whatever.
Saba, I will share only one my experience. I was attending a mock session for part 3 MRCOG, and you told me that we were discussing that real agenda was that patient is actually crying, and you need to console her, and the 4-minute task was only to for the crying, right? The
Yeah.
same happened, and in which cabin the patient was actually came with nausea, vomiting in pregnancy, and she was just vomiting. She actually, I want to talk with her, and she was just vomiting. She's throwing up, and she was actually very good actor. So, and the agenda was that you don't have to start a discussion. You have to
Yeah.
wait, calm her, call. Actually, you have to say her,
Yeah.
I'm calling
Antiemetic. Yeah. Her warm.
nurse, and she will come and she will give you antiemetic. And when you will be stable, then we will start the discussion. Until
Yeah.
unless you are not comfortable, we are not actually starting it. And that was the point where the examiner, where the role player is giving the marks. She was not interested in any other thing. So
So that
I
was
was
your best. So that was your best station, I believe.
no, it was not it was my worst station. So I learned a lot.
And it happened with me, Dr. Hira. Once my patient was crying, and because, like, trust me, we were discussing the mock outside. So inside, I came to know the scenario was this. They changed all the history for me. She was having, like, I guess she was having two abortions, and this was her third time she was pregnant, and it was anomalous baby inside. So she changed all the history. She said, like, I had three ectopics. You guys removed my tube. I am pregnant with the IVF. So she can speak anyway. You trust me? She can speak in any way. There is not like a fixed history. Outside, I was told like this. Inside, when I went patient changed her history, and she started crying. So I thought, like, okay, anomalous. Maybe it was like not my Down syndrome something. So I thought, like, I would counsel her in a positive way. She cried. I offered her vibe, but she cried very loudly. She was like, you are not understanding what I'm going through. She literally, when she was acting, there was tear in her eyes. So at that time I realized that I'm not a good in this. So I have to be more empathetic. So when I came out, when they gave us feedback, they told us the station was all about the empathy. It was not about the Down syndrome or anything else. It was the empathy station. So anything can come, guys. Who is our molar candidate, please?
Yes, doctor.
And another mistake, don't ask the next candidate what's going on in the cabin. Maybe that candidate, the patient, the role player give her his different history. Maybe she will give you different history. The case should be same. Obviously, if there is a breech baby, so it will be a breech baby, but the patient can change her history. They don't even remember what she told last candidate. But the examiner will mark that history and the risk factor, and he wants you to manage that case, tackling those risk factors. If she tells the B positive to one candidate and O negative to other candidates, so the next candidate of the O negative has to do the anti-D things. Okay, guys, can we start, Asra?
Yes, doctor.
Enter in the cubicle and read your scenario. This is your scenario.
Hello, I'm Asta. This is my exam code.
Read your scenario, doctor.
Hello, I'm Dr. Asra. I have read one of the exam candidates. I have read the instruction. Oh, sorry. Hello, I am Dr. Asra, one of the doctors in the guidance unit. May I know the name and age?
My name is Linda and I'm 28 years.
Okay. How would you like me to address you, Linda?
Linda is fine, doctor.
Okay, Linda. I can see from your notes that you are here to discuss the report with me. Am I clear? Am I right?
Yes, doctor. You guys did my surgery 2 weeks before, and I don't know. Today you guys called me, so I came.
Okay. So, what are your concerns and expectations on this appointment?
Astra, speak loudly. I can't hear you. It's a difficulty.
Okay. What are your concerns and expectations from this appointment, Linda?
Doctor, you guys are telling me the report. You send my evacuation products, and now you call me for that. So is everything okay?
Okay, okay, okay. Okay, would you like me to discuss your report first, or I would like to ask you questions so that to know more about your problem, and then I will need to run some to do your examination and then review your investigation so that we can have a better plan of management.
That's fine for me, doctor. Please go ahead.
Okay. Then in the last, I will pick your appointment with my consultant and provide you the patient information details. How that sounds good, Linda?
Perfect, doctor.
Okay. So Linda, I would like to ask you that you have a surgery done for the miscarriage. How was your recovery?
Doctor, initially it was difficult for me, but now I am looking forward to it. Maybe it was not to do this. Everything was good.
Everything is good. Any complication at that time? Any bleeding or any other thing? Would you like me to address?
No, doctor.
Okay. I would like to ask you a question from your pregnancy, whether it was a planned pregnancy or spontaneous?
Yes, doctor. Yes, doctor. It was planned and spontaneous.
Okay. Have you taken folic acid supplements or blood test or booking scans?
Yes, doctor. I was with you guys, and when I came on the scan, you told me that there is no heartbeat.
Okay. Okay. Is there any symptoms of any pain, bleeding, or passage of clots or vesicles from the down?
No, doctor.
No. Okay. Is there any history of shortness of breath or
No,
cough with the
doctor.
teeth? No. Right. Okay. Now, so you are pregnant first time, or you have any baby before?
This is my second pregnancy, doctor. Previously, I also had a miscarriage.
Okay. The previous you had a miscarriage. Have you ever gone through the lab test for this after miscarriage? What was the report?
That was fine, doctor.
That was fine. Okay. Uh, so have you ever used any method of contraception? Your smears are up to date.
We use protection, and yes, doctor, my smears are up to date.
Okay. I beg your pardon if you have any sexually spreading disease.
No, doctor.
Okay. So any history of medical concern you are following your GP?
No, doctor.
Any allergy to medication or food?
No, doctor.
Any surgery apart from this of the abdomen or the down below?
No, doctor.
Are you aware of your blood group or?
It's O negative, doctor.
Okay. Any history of blood preservations or blood transfusion?
No, doctor.
Any family history of concern?
What? Sorry, come again?
Any family history of concern?
No, doctor.
Okay. How about your social habits?
I openly drink alcohol with my friends, but not that much.
Okay. And how is your social support?
That's fine.
Okay. Are you aware of your BMI, height to weight ratio?
That's normal, doctor.
Okay. Are you feeling any depressed or lack of interest or low mood?
No, doctor.
Okay. Thank you for sharing this information. Would you like to add some more things?
No, doctor, but why we're asking so much details? Please tell me about my report. Is anything fine?
Yes, yes. Coming to your concern, after confirming your, I can see that you are here alone. If there is anyone, someone waiting for you outside, you can call. May I call her for you?
No, doctor, I'm fine.
Okay. Or if you like someone, or would I like to call one of my nurse to be with you, as I have to share a lot of information with you.
Doctor, if you are making me worry, okay, please give me a nurse. I would like to help her. Please
Okay.
continue, doctor. What's happening? What's going
So,
on?
Linda, after confirming your name, date of birth, and file number on your report, it is report starting the meaning of this.
Sorry?
After confirming your name, date of birth, and file number on your report, I'm really sorry to tell you that the pregnancy, you have a pregnancy which is not normal.
What do you
It is
mean
like,
by doctor?
I can understand that you are going through a very hard time, but don't worry, me and all of my team are with you. This pregnancy is not normal. In this pregnancy, what happens that there is a grape-like structure which grows in your womb. May I draw it for you? This is your womb, and these are the there's no baby in your womb. It is just only the grape-like structure. Have you ever, in our language, it is known as the molar pregnancy. Have you ever heard about it?
No, doctor. What do you mean by abnormal? It's because of me. My cells are abnormal.
No, it is not for you. It is not because of you. You didn't do anything or from your. There are some risk factors that is those patients, those people who are underage, that is less than 20 or more advanced age, more than 40, or some sort of ethnicity. They may have these situations, or there may be a previous history of these type of pregnancy. They are at the high risk. So it is not for you.
Doctor, you already removed that baby. You already removed that. What are you telling me? Like it's abnormal. What does mean?
It means that the baby, the report is showing that the baby is the which you have conceived is not a normal baby. It was a molar tissue or the molar pregnancy. That is a grape-like structure.
Okay. What should we do now, doctor?
Okay. Now coming to your the management plan. The management for you in your case already you have done the already you have done the evacuation. Now further you will need a follow up. For the follow up, before the follow up, I will advise you to do the proper contraception. That is the barrier method of contraception, and then after that we will do the follow up. That is, we will do the pregnancy hormones every weekly until if it is normal within the 56 days, then we will further continue your follow-up after 6 months of the evacuation. If it is not within the 56 days, then we will continue the follow-up after the 6 months after the normalization of the your hormones levels. Are you with me? Am I clear so far?
Yes, doctor, but why you will call me for 6 months? What you will do that in those 6 months?
We will check your levels of the hormone, because in these situations what happens that fortunately these disease that is this type of pregnancy you have, it is not a condition in which is spreading to your womb, but there is a 20% chances to have a spread in your womb, or there may be the root may be present. So for assessing this, we are going to do your the hormones levels weekly basis. Am I clear?
Okay. Yes, doctor.
Okay. If we cannot do, it may be due to the rise in the level, or it may be due to some spreading of the disease in your womb. There may be the life-threatening bleeding, or there may be the perforation of your womb, or serious complications may occur.
Time up. So how was your station? How you performed? What are your remarks?
Very well.
Sorry?
I didn't perform good.
No. I wrote it like you were speaking, and I write the word beautiful.
Oh.
It was so perfect. It was so perfect. Forget about the management part. There were certain deficiencies as well. I will come about that. But you address in the start, you build a rapport. You asked like, may I call you Linda? Is that fine? You told me like what you're gonna ask more questions and we'll discuss. My management is the fine with me. There was a rapport building part. I was being an open and I was trusting on you. You could have been asking like what you do you have any idea, you asked like this. So about your report, you said like simply I was unaware. You asked about that, I was unaware. So there was an open question. You wanted me to involve you put me for first. That was a very nice start. About the early pregnancy details question, since she has done the miscarriage, that has been done. So you don't need to touch and dig in so much except for the like passage of the clots or passage of the grapes like structure. Okay, that was fine. Early pregnancy, the conception detail like spontaneous or planned, you simply ask it was your planned conception or it was your planned pregnancy, that's it. Like don't ask in the chunks and again because you don't have time in SPT. But for the long case, this is the ideal way. You completed your history at 4 minutes and 30 seconds. Yeah. So it should be completed within 4 minutes. Like within 3 minutes, ideally in SPT, we complete the history within 3 minutes. But with the practice, you can come like more shrink your question, like one liner, because like in the you touch everything. That was so perfect. You touch everything. Even you ask the mental question, but you ask, have you feeling depressed or down, or have you been feeling down? Just this word, have you been feeling down? Don't ask like low mood past few days, these because this you ask in the long case. Please ask this in the long case, but here one word only. Touch all the bullets just with the one word only. Coming toward the beautiful BBN, very beautiful. You asked to involve the someone, even if was not there, she was alone, she don't have anyone with her. You asked your chaperone or nurse for me. That was a beautiful part. Now you tell me there was you are giving me too much information. That was the beautiful warning shots. This is all examiner has. I was doing tick 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 tick. I had the key. I was doing tick 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 tick. Okay, don't tell. Coming towards how you open up with this. The pathologist look at the pregnancy tissue under the microscope, which we sent after your surgery. It came like that. It is an abnormal type of pregnancy called the partial molar pregnancy or the complete molar, whatever it is. Here I said why this happened or my cells are abnormal. I was giving you a clue. Draw like thread-like structures, usually one egg from mother and one cell like sperm from the father. They know the egg and sperm thing, by the way. So the genetic material development comes in this way. But in your case, what has happened, if that's the partial mole, you can say the egg and the sperm meet with one extra sperm, one extra, you have two sperm and one egg. That is called the partial molar. You have an empty egg and two sperm. That is called the complete mole. Whatever it comes, don't tell her the details. If she's partial mole, tell her only partial mole. Don't tell the complete mole. You were telling the risk factor like less than age or like you were telling like teenage or more age. These should not be telling the risk factor to the patient if she don't have. If she is like, I can if I say my age is 18 years, so you can say there is a risk factor in 18 years people. Okay. SPT, don't tell all the risk factors to the patient, like why this happened to you. But in the long case, you tell this to the examiner in structured discussion. If the examiner asks what are the risk factors, then you can tell. So here you did it beautifully, just only the genetic material, one egg, two sperm story you can incorporate. Now the baby genetic material is abnormally from the beginning. So what we had, if you were diagnosed, is like before the DNC, we also had we will do the DNC for that purpose, but since it's already done for the completion, for your safety, we have to do the monitoring because this pregnancy can invade in your body. This is one like warning shot or one safety point why she should come to your clinic. She should be like going away, okay, my DNC done, and doctor was saying something abnormal. Thank God they removed that abnormal part. She could stay at home. You need to tell her the need for the follow-up because it can invade her body, it can grow, it can incorporate in the form of the roots, it can affect your organs. I'm not here to make you afraid. I'm not here. I want your safety. So this happens this way. We have to follow up. Like you told follow up beautifully. That was perfect. The pregnancy cannot grow normally, and why it's ended is a miscarriage. These slides, I'm giving you the words. You can like remember these lines for the molar pregnancy. Tissue was completely removed. You don't need to have any surgery. We will do your pregnancy hormones until it become normal. For the partial mode, you guys need like we do the 2 follow-up 4 week apart when it become normal. And for the complete mole, I already told. Her scenario was, I guess, complete mole. So here, why was I called back? We came these abnormal tissues, so to keep you safe, to discuss with further, I was reports are available with us, so we call you back. Is it cancer? I could ask, like I didn't ask, but you have to tell no, it is not cancer. Very rarely the tissue can continue to grow, but we detected and treated it earlier in your case. Guys, like I told last time, crossing the road, if there is a risk factor, don't tell the patient like you can have an accident. If she in the partial mode she don't have. You keep her happy, like continue to grow. But in your case, we detected and treated earlier. To keep you safe, we will track this. We will make sure it won't develop into cancer. Did something wrong? Not your fault. Random genetic error. Will it affect my fertility? No, it won't affect. You can continue normal, but scan early. This is the safety point. How long will I need to follow up? You follow up according to the partial mole or the complete mole. Do I need a chemotherapy for the partial mole? You know, there's a like 0.5% or 1% chemotherapy. So for partial mole, we don't. But if your patient is aware and your mole is complete mole, then you can tell her the chemotherapy as well. This can come in the structured discussion. These are all those points again. This can come in the structured discussion. Here, examiner can ask like FIGO scoring. He won't ask much detail and he won't give throwing scenario to you and ask calculate the FIGO score and tell and discuss with me. No. He will simply ask the FIGO score is 6. What is the treatment? You will do the methotrexate alternatively with the folinic acid. If the examiner asks you the score is 8, say for example 7, so you will tell the IMACO and tell all the regime and the follow-up according. This much Viva is enough. The side effect, the chemotherapy, just one liner, like leukopenia, neutropenia, hair loss, one liner, bone marrow depression, one liner only, not much. This is for structure discussion, I'm telling you. But here for the SPT, Asra covered it very beautifully. SPT is all about the talking about the patient, counseling the patient, address her emotion, breaking bad news, empathetically. You treat your patient, you ask her, you have any other question. SPT is all about that. It is okay, forget about if you did not go towards the perfect management and you did not tell the right. If your patient is happy, you got your marks. Red flag sign should be addressed in her case, like she was on the follow-up. So, Asra, you told these in the follow-up, you will call me a pregnancy harm, but you told the red flag signs?
No, doctor, time up.
So that was the safety point. So if you don't tell me this, your 1 mark will be deducted for the safety. Okay. This was another safety point. Usually it carries solid 1 mark. You have to give her information leaflet. And here in the gestational trophoblastic disease, you have to contact them with the centers. I have a slide where the centers name are here. Usually they have the National Trophoblastic Center in the Cork City. So we connect the patient to there and otherwise one with the National Maternity Center something. They have the 2 centers in the Ireland. We have to give the contact number and 24/7 information. Plus, there's a safety point to be furthermore. She can go over there, how she will manage the follow-up. These things should be addressed if she has the complete mole over there. Because here the examiner wants to do all the GTD things, chemotherapy, and to tell her the 6 month and to make her agree for your prolonged follow-up. And to tell her when she can do the pregnancy again, like waiting for the 1 year, waiting for the 6 month, whatever comes. Counseling group, patient support advice. Always remember, guys, this thing has 1 marks. 1 marks, counseling and support group. whenever there's a difficulty, like she has abnormal baby, she has the miscarriage, ectopic pregnancy, molar pregnancy, or she has like bilateral self-injectomy due to hydrosalpinx, whatever, or infertility patient, counseling and sport group carry 1 marks. Don't let examiner to take this marks with him. Please snatch these marks. You know these things. Just speak in one liner. I will attach to the counselor and I can attach to the sport group. Lot of people are going through these things. You will feel better. You can talk with, share with them. Like if you have time, you speak more. Otherwise, just connect. Would you like me to go over any part again? Because this was the molar pregnancy and genetic material. This is a new type of a thing. So you can ask. So summary national center in the court, guys. The center I was mentioning before she finished. This is your structured discussion part. As I was telling this is structured discussion part, and the examiner can ask chemotherapy when to require, what are the risk category, low risk and high risk. The one liner only. Here in RCPI people, they don't dig in the guidelines so much. Trust me, they won't ask the much details. Contraception and safety point. Avoid intrauterine device until BTEX is normal. You will give her the barrier protection, and you will ask her, she has to like avoid the pregnancy till the completion of the follow-up in the partial mole. And for that complete mole, if she has chemotherapy like 1 month, and for complete mole till like 6 months and all that. So fertility prognosis, anti-D requirement. If she told you blood group O negative, you will give her anti-D until or unless you confirm from the histopathology is complete mole, then don't give her. If the patient has complete mole, then no need of anti-D, but if has the partial mole, then you give. You know why is this? Because the complete mole, there is no maternal tissue, no maternal RBCs were attacked, so no need for anti-D. Registration was must, follow up was must with the molar pregnancy. Usually they don't die with the pregnancy, they die with the malignancy later on spreading in their blood. So that was the perfect safety point. You have to attach them early. You have to tell the need of the follow-up in the molar pregnancy. Here is again the beautiful slide with the replacement gestational trophoblastic disease. You sell abnormal pregnancy tissue that has the potential to grow. Here, they grow abnormally and they have the potential to grow in their body later on. Two types of molar pregnancies, regular monitoring, medicine to remove the remaining cells like chemotherapy. You can say there's a high potency medicine, we call it chemotherapy. FIGO score, what you say, FIGO score system to plan the treatment. If she says, who will decide I will have the multiple drugs or the single drug, if the SPT goes in that way, or if the station is that you have to counsel your patient for the chemotherapy. If the SPT comes in this way, counsel your patient, she has the complete mole, and counsel her for the chemotherapy. Her score is this is all it won't come calculate her score, but they will give you score. So in that case, just use system to plan the treatment with score. These are two type of scores. You fall in this score. So in this score, we will do this. These are the side effects. We will do this monitoring. You have to do the contraception. These are the red flag signs. If you face them, come immediately at the end, connect her with the sport group, connect her with the GTD center. So that SPT can address in that way. Metastasis spread to the other organs and combined drug treatment. You should know these words. OSCE is all about speaking right words. It's not about the knowledge. Knowledge can be, like for me, it's 50 less than 50% knowledge part, but rest is all about the speaking. You guys performed your best SPT. You didn't use the medical jargon. I was very happy. Everything was perfect. Just more polishing and you are there. These are the centers contact number. They won't ask you. They won't ask you at all. Just for your, okay. These domains I already discussed. The key is like this. These like communication, I will take 1 mark. If you have been clear, calm, you address, like you ask the open question, you ask, may I call you this? You were empathetic toward me, because these stations are very critical. These are very bad news to hear for any woman, any reproductive age. We won't expect these type of the news from our doctor. So your flow should be this: introduction, history, result, and management, rather than you doing management and then you jump in my history again. You did not do that. So that was perfect. Then accuracy, you know, the size of the, like in ectopic pregnancy, you are following the guideline. In Irish, for this you are following the guideline. You were empathetic, has 1 mark. You mentioned my safety, NTD, follow up, and red flag. These 3 things, it carries like usually 1.5 or 2 marks they have for this. Safety point is very important for Irish people. Mental illness, asking about the mental illness or depression is very important for them. Asking about the reservation and blood group is very important for them. For SPD, we are focusing on SPD key. So for SPD, I'm telling you this. Even in the long case as well, but these things carry marks. And the lawyer, you summarize, check her understanding. You want me to add anything? Like when you hand it over, you connect her the DTD center, you give her information leaflet, you tell her the follow-up NTD, you want me to add anything else? If your patient says no, doctor, then perfect. You are there. The station is 10 by 10. If the patient says, doctor, tell me this, it means you might be left something in your history and the patient is asking again 10 by 10. That's perfect. But if your bell rings in and you walk out of the door and a patient is still like at the last moment, like at 9 minutes or 9 minutes, 30 seconds, my patient still has anxious face or she is still not satisfied and she's asking like she's asking something from me and she obviously she won't give me a clear clue in front of the examiner. But if she's asking is not satisfied, then there's like difficulty, little bit difficult. Yes, Arjun. Hello.
Hello.
Yes, I can hear you.
Yeah, thank you. In RCOG, they mentioned that if there's on histopathology, there is a complete hydatiform mole, then there is no need of NTD. And so in this case, we will not offer her the NTD injection, isn't it?
If I told you, if it's complete mole, then there is no maternal cells, no need of NTD. But if you don't have histopathology, if you are counseling her like she's for ultrasound, she came with the ultrasound and she has the complete mole picture, then in ultrasound it's complete mole, you will give her NTD after the surgery. But in your case, in your patient, she was done the surgery, now histopathology, after 14 days the report was complete mole, so no need of NTD.
Yes, exactly. So Arjuman, here is a trick, because timeline is important. If you are doing suction evacuation for complete mole, you have to give NTD. But if you are discussing histopathology, then you don't need. Got it?
Because you already crossed those 10 days, right?
Yes. You cross 72 hours.
Yeah, thank you.
But Arjuman, if the patient comes with the scan, whatever the mole, if even is complete mole, partial mole, give her NTD because the confirmation only on histopathology. If it is complete mole on ultrasound, maybe it come partial mole on the histopathology. So for the ultrasound or before the surgery, as Dr. Hira said, with the surgery, give NTD. But for the histopathology, you tell the patient accordingly. If it's partial, need of NTD. If it's not partial, it's complete, no need.
Yeah, I just asking about this patient.
Yeah, this question come in the structure discussion. Examiner will ask you very details.
Dr. Saba, in scenario there we written complete mole, and in actually explanation we write partial mole. So this is a typing error.
But I told Arjuman, they know this. It can come in any way.
This was actually a mistake, our typing error in the slide, in the PPT, which I have noticed.
I saw that, Dr. Hira. In the first slide, it was complete, but in the discussion, it was the partial. I didn't correct it because they know that we have to do it in both ways.
So it was just a typing error. Depends whether they give partial or complete, you have to plan accordingly.
Yes.
Dr. Saba, you're very smart. You started like SPT, and then you add every possible structure discussion. And you made it a long, actually you completed that topic in 3 ways: SPT, SD, and long case. So again, it is very impressive way of conducting that session, because SPT cover, SD cover.
Dr. Hira, they will be like, next time they will asking Dr. Saba, you don't be our patient, Dr. Hira will be our patient.
तो इसमें इनका फायदा है ना, like they covered the topic by all three means.
Yes,
वैसे बाय द वे डॉक्टर हिरा, आप क्यों नहीं बनती पेशेंट? आप पेशेंट
मैं
बना
बनती
करें
हूँ.
ना एसपीटी में, और डॉक्टर सबा एग्जामिनर बना करें ना,
Okay,
ताकि
we
हमारी
will.
और
I
गलतियां
will.
निकाला
If
करें.
this is your
That's a
feedback,
suggestion. I mean, you,
no,
yeah.
no, it's very good, positive suggestion, and I will discuss it with Dr. Saba. And why not? If you want me to be a role player.
in this way I will be able to mark and point out the mistakes more. Like I can have my key tick more correctly.
Exactly.
Okay.
Because this way they ask me a question, I'm writing as a feedback, and then what she asked me, I have to make answers.
Okay, I will.
Do we have time for the next station, or we'll do it next time, Dr. Hira?
I think if you are comfortable, we can take long case with this session, because
I
in
have-
Sunday session, then we will again have 3 to 4 topics, and it will be difficult for you and the audience to actually.
Have half an hour for this.
So Dr. Monia is here, and Dr. Monia, are you ready for this long case? Hello, Monia. मोनिया नमाज पढ़ने चली गई है. Anyone else?
Assalamu alaikum, ma'am.
Okay, you are back.
Yeah. Because I came just before 10 minutes from the hospital, na? That's why. Yeah, ma'am,
Last time you were offering prayer this time, so I guess you were also offering prayer.
No,
then.
now it is 1:45 now. So this prayer finished already. Zohor finished.
Okay. So should we start long case with you?
I can do it, ma'am. Actually, I was preparing for the molar. No problem. I will do this long case or no problem. Let me check. Okay. That means, ma'am, 12 minutes for the history and examination and investigation, and then 12 minutes for examination plus management. Is that like that?
Yes, it's like that. And I will ask summarize your case as well. Usually examiner don't ask, but they can ask as well. It's depend upon examiner. So in your case, we will prepare all our cases to summarize as well. Okay.
Okay, ma'am.
Dr. Hira, you will be the patient, because I will writing her history and all those.
So, Dr. Saba, one thing. Have you actually discussed that flow sheet of SPT, which you were making, like how to start intro, aim, agenda? I think if you shared, I missed that slide. There were 2 slides.
Let me go back. Wait. Can you guys see, Dr. Hira?
Not. Yes, we can. I think it was in molar PPT.
Molar? Okay. Let me go back to molar. This is molar. I merged them. So you send them separately, I merged them. This is molar.
Okay. Go back more.
This one?
No. Okay, I'm going to share and you can explain it. I
This
have
one,
that.
Dr. Hira?
Yes. This one. You put so much effort on it, and why you skipped it? So it will give a good idea about how to start your SPT specifically for the beginners.
Yes, these were beautiful slide. Actually, I plan to spend much time on these. I skip these. Okay, guys, like for the early pregnancy, if you ask what is the perfect
So, Dr.
format,
Saba, I want this slide to be actually in a slideshow, so the view will be maximum.
Dr. Hira, when I do in a slideshow, it goes away. It comes like, okay, I will skip 26 slides. It comes at starting. Won't go on
Oh,
that. First slide number 26.
you are using Mac?
No, I'm using my HP. Okay, guys, here. For SPT, let's do the perfect format. Whatever SPT comes for you, either she has the polyp report, she has the anomalous report, she has the report of chromosomal analysis, she has amniocentesis report, whatever the SPT comes in your way, you will start the rapport building is here. Your patient will answer happily, or your patient will be like saying, you okay, go away, doctor. It starts all from your style of introduction and your rapport building. Hello, I'm Dr. Hira, one of the doctors in the clinic today. May I confirm your name and age, please? If it is given. If it is not, may I ask your name and age, please? What would you prefer me to call you? Would you like me to call like this? Okay, these three questions never be missed. You can formulate these questions in your style, but these 3 points being an examiner, here is introduction rapport. For example, this is my key. I will give you 1 mark, or I will tick your 1 mark over here. Usually they have like good, excellent, 1.5, 0.5 like this. So I will tick 0.5, I will tick 1.5 if you do like this. If you skip anything, I told you I'm Miss Monica. You directly, okay, Miss Monica, tell me this. Why? You are not my childhood friend. Please take my permission to call me Miss Monica, or maybe I mind it. So these 3 completion, this is very beautiful slide. Thank you, Dr. Hira, for reminding. Now the aim and concern or agenda setting should be like this. Linda, I understand you have asked the permission. Okay, Monica, I understand you must be concerned. Let me check few details with you. You had a procedure 2 weeks ago for the miscarriage. Is that correct? Is this for your molar? Or if she brings up the report of ultrasound, it is abnormal baby. I can see that you had a pregnancy of this much week and you are here with an ultrasound report to discuss about your baby. Am I right? Or is that fine? Is that correct? Do you have any specific concerns or expectations? This Asra asked this very beautifully for any expectation from this consultation. So this is the aim and agenda. Guys, if you think like, oh, there is a less time, I won't be able to speak. If you will be doing in the flow, you will know you are speaking this without wasting time. I understand you had a procedure 2 weeks ago, so this is the same. Before we go through your result, this was like how to ask your patient very nicely. If she's sad, she's anxious, no, doctor, tell me what's up. Before we go through your results, I need to ask you a few questions, and then I will explain the result and possible diagnosis. I will answer you all your concerns, provide you with written information, need to examine you, presence of chaperone. I'll update my consultant or GP result. Is that okay? I will connect you with the sport information leaflet, whatever you can add these lines. So if you say this, you will connect me the consultant, you will give me the information leaflet and the contacts or GTD center contact number at the end. So that usually guys don't say the GTD center contact because you don't know the molar is coming. So you will give me the contact number, whatever. These things in the line, if you forget at the end, you already did this. Examiner will give you marks. Usually people say it earlier, but we can do in the both ways. If you say it earlier, you have less time, say at the end as well. So agenda setting is like what we are going through this or that, the format like one slide has that. I'll mark that again. So information gathering start from here. Tell me more about you. Dear, we don't say the patient, so it's a typo error. Tell me more about you. How you have been feeling since the procedure, if she has done the DMC. Or if she has any surgery, then you ask, how are you feeling now? Otherwise, do you know anything about your report? Do you know anything? Or if she's having the bleeding, tell me more about yourself. Tell me about your problem. You can put any question in here, guys. These 2 slides are very, very important. If patient insists before history to know about the result, respect her wishes. Here, the examiner has the autonomy. He has might be written here autonomy, he will tick it or not. according to this. I know we feel comfortable, we go with the history and then we discuss with the report, but a patient can interrupt you. So here when you are talking and when you are taking the history, the examiner will check your communication skill. Like, and then when someone tells you so much questions, you have a courtesy, please say her thank you for details or thanks for answering my question. Thanks for opening up with me. Okay, now before any BBN, guys, please, Asra did it very beautifully, Hira did it very beautifully, but I had to cry to get her attention. Give her warning shots. You need 2 or 3 warning shots. I can see you are alone here today. You want like someone to join in here in the clinic. You want to call someone inside the clinic. You want to call whatever. Number 1. Number 2, it's not the expected news. It's not the news we were expecting. If she has like for the scan and she was pregnant, she's excited. She was excited. It's not up to the expectations today. I'm sorry about that. I have to be the bearer of this news, but I have to be honest with you. Like, put anything in the warning shots. Call your chaperone if she's alone. If she's like a teenage, like the teenage termination of pregnancy, there's a station Dr. Hira was talking about. In that case, she is alone. She lives in the hostel. You ask her the chaperone, presence of the chaperone, bad news, tell her that bearing the bad news, I'm the one who will be, but I have to be honest. You want me to continue. So these 2 or 3 warning shots, this has at least 2 or 3 marks, guys. 2 or 3 marks. Rest parts 1, 1, 1, 1, 1. This communication and this pause, there should be pause, like you count, you do the counting or you say A, B, C, D, E, F. You have to pause. Like for second, at least 20 seconds, there should be silence. You should be looking into her eyes. Like, it's not like you are also sad and you are here crying and moaning over that report, but you give her you respect her emotions. You are giving the pause and you look confident, but give with the confident look. Give this BBN. Then always report reading style should it carry marks, guys. If I forget to tell you, I guess the Hira, maybe Hira also checked that, but Asra, I mentioned beautiful report reading. She confirmed my name, age, hospital number, and reference number. And she tell me the report belongs to you. Whatever reports, amniocentesis report, whatever the reports. The reason you were called back is here in our patient. The reason you were called back is because your test results are now available, or the histopathology report or the details reports are available. They have shown something slightly different from a routine miscarriage. I would like to explain what that means, how we manage it, what sports you will receive. Is that way? Is that fine with you? Can I continue with that? Here, maybe if she says no, if she cries over, your scenario will be up till that. These things don't carry marks. If she cries over prolonged, or if she asks like here and there and go by here and there. But if she will give you, yes, doctor, please go ahead. I'm okay now. I feel you better. You can ask her. I can arrange another consultation for you. Is that fine for you? Or you want me to do in this sitting? I know it's too much stuff for you. I know. So again, closing should be beautiful. These 2 slides carry marks. This is your SPT. These 2 slides. Whenever next time you perform SPT, please open these 2 slides and put your question and put your things in these. Trust me, you will get 100 out of 10. So closing should be beautiful. Your pregnancy, like maybe she forgot anything. So to end up this discussion, I know your pregnancy. Say in any form, remind her of summarized one-liner. Your pregnancy tissue showed a rare but very treatable type of partial molar pregnancy. You see how beautifully, Dr. Hira, this slide is perfectly beautiful. Here you are telling her this is abnormal pregnancy, and here you are beautifully telling her it's treatable. Now she will she will be with you for the 6 months or 1 year, whatever time you give her. She will be here because it's a very treatable. It's in her hand. You need to tell her this is all the simulated patient task. You will be followed up through the National Trophoblastic Disease Center in the Cork or National Maternity Hospital. Take one name, that's enough. There you can say there are another center which are suitable to your location. We can connect you with that. Written information leaflet, support group, counselor, more people around her may be having these things. You are not alone in this. We will keep in touch until your results are completely back to normal. So you see, this is the happy ending. You have to happy ending. Do you have any other question before we finish? Pause for patient response and thanks her for attending. Here you should say me thank you. Next time make a habit when I give you history or when any patient, when any role player give you history, say her thanks for answering my question. Say her thanks for addressing today whatever the consultation. Any confusion in these two slides? Dr. Hira, you can add anything I missed in these.
No, you made it beautiful. You made it beautiful.
You, Dr. Hira, I just read that. When you send this, I was thinking this was the format I used to practice at my SPT, but I never had these type of slides. These were the much needed slides. Guys, any confusion? I'm ready to read again 2 times, 3 times. I'm ready for it. Please, please, please make it clear. Today our SPT thing should be done perfectly, no confusion. Next SPT should be perfectly on this module.
Yes,
in this
sure.
format. Someone
Yes,
of
sure.
you was saying in the chat box or in that like we want ideal template. So for SPT, this is ideal template. But again, the way you carry your station and you address all those things doesn't matter. I have my own style. Hira has her own style. Monia has her own style. So examiner knows you guys are different, but address these parts only. These things can be changed, but you have to address these parts maybe before or later. But start should be here. Introduction, introduce yourself. I am Dr. This. Build her a rapport that you have ethics or you are asking her, addressing her, your body tone, your language. This is your rapport building. Then aim, concerns, agenda setting, information gathering, all the history, safety points, especially in the information gathering, safety points. So here, report reading style, then all the details and discussion at the end. Try to summarize if you have time. Otherwise, try to ask her. And another question is in this template, only one thing add, please. Are you with me? Are you with me? Even in each slide, please write, are you with me? Are you understanding? Are you with me? Am I audible? Am I clear? Are you with me? Or at least 2 or 3 times you should ask. At the end, make her connect with the support group. Ask her if she any question is left. She want to ask anything. If yes, ask. Otherwise, your station is done. When you guys will practice, trust me, when you guys will practice, your history will be ended in 3 or 4 minutes. Rest all these, you can do it here, 3 or 4 minutes, 3 minutes for this, reaching up to this point. Then patient question and your explanation. All this slide has the 6 minutes. You can do it. Even before time, you will finish it. You will see, I'll be there. I'll be telling you guys, you were the one who took 14 minutes in the first session. Today, you finish it in 8 minutes. You will do that, inshallah. We will reach at that point. Okay, so guys, Dr. Hira, now I have just 15 minutes left. So should I go with the long case?
It's up to you, Dr. Saba. But I was thinking one thing. So
Yes.
this is our first session with you, and they are too confident regarding SPTs. And what will be the level of confidence when you will be conducting your 24th session with them? They will be more better than us.
Inshallah. The only thing if they will attend, if they are up to the recordings, if they listen the recordings in their bed or with their headphones, trust me, it won't benefit much. OSCE is all about the practice. So guys, this is my request. I know the time is not suitable to you. We will try to be a suitable time with you guys, but please, please, please practice. Speak.
Dr. Saba, I was thinking we should take next session only on long cases. It will be a better idea if we will finish this session here. So they can only work on SPTs meanwhile, and they are just starting the course. We shouldn't jumble up so many things. We can be slow.
That's the perfect. Guys, friends, if you have like PT from any other module, these slides will be that for that module as well. So Dr. Hira is right. Let's finish it on the SPT today.
Yeah.
And next time we will incorporate.
Dr. Saba, I was thinking to share some read-only SPTs on their portal. So meanwhile, they can read those topics as well, and they can work only on SPTs in next 2 or 3 days.
Yeah, that's perfect way. That's the very because they will having one SPT from early pregnancy. Usually they keep it.
Yes, Assalamu alaikum, Dr. Saba, how are you? And just in the last moment, I came to listen this one. I saw this one classes because I'm supposed to be present this long case miscarriage, but unfortunately yesterday I was on call and I reached late here in this home. Then I cannot.
So it was your luck. We are not doing it today. We will do
it. So inshallah, next time I will present because I couldn't read this anything.
Okay.
I was trying
next time Dr. Monia and Shazia will present long cases.
Yeah.
Ma'am, actually, I was prepared today also. I can present, but today no time. As if I think Saba ma'am is going somewhere, so no time. But if you want, I can present even today the miscarriage.
Okay, Monia, you will present long case next time. And with you, Dr. Shazia will take one long case. What about Dr. Arjumant? And Asra? If you are ready, we will give you one long case more. So we can happily take 4 long cases in next session.
Yes, obviously, I will.
Keep it 3 long case.
Okay.
We can give them done in next time. It's okay. But every student will do at least 6, 7 long case. Don't worry.
Okay. Doctor, will you please tell me about the topic of long case for me?
Okay, it will be on one on nausea and vomiting in pregnancy, and one definitely from will be the recurrent pregnancy losses. I will inform in your Telegram group.
Okay, thank you.
Saba ma'am, can I ask you something?
Yeah.
I'm sorry to ask you that you were telling that when we will introduce ourselves to the patient, that may I know your name and age, please. Then after that, we should ask that may I address you, suppose XY, whatever the name. So one of the med exam doctor, she was telling, don't do this because already she told you the name. It is the wasting of time. But your point is valid that maybe she may mind what I will call her, she may mind. So which one should follow, ma'am?
Just if the scenario or the paper in front of you or the ultrasound report has the patient name like Sila, 24 years, is here in the clinic today. So here, may I confirm your name and age? You confirm.
Yeah, after that another question was, may I call you, suppose she said my name is XY, so may I call you X? Should I tell this one?
Yeah, you ask it carries marks, Monia. It's a communication and rapport building carry marks. So rapport cannot be built if you suppose me to ask Monia, may I call you Monia? Is the fine? One line, it takes like one line. When you practice, Monia, when you will be practiced, you will do that, it won't take much time.
No, that I know, but one ma'am told not to do this because this is not good.
Yeah, everyone have different opinion.
Yeah, that's why I want to
confirm. Will add. Arjuman, you will add your input. You recently passed your MRCOG 3 exam. So during actually rapport time, so you use that thing now?
Yes. Making a rapport.
So this is the standard international way of communication. You can't skip it.
Actually, I started with this one. In between, I took that class for med exam that Dr. Shazia was telling, don't do this.
No, don't use any actually company or mentor name. We respect a lot for them. And maybe she might be telling you in other context. So
No,
you can.
no. In general, ma'am, she took one class. In general, she was telling how to approach that. Now that Dr. Saba was
Okay,
telling
Monia,
now
hold
that
on, relax. So mentor to mentor, many can have different, opinion. See, in one case, Dr. Saba were doing salpingectomy, and I was in the favor of salpingectomy. We both are right at the same time.
okay. So I want to know in the exam hall, which is the perfect one. So at least I can get some marks. That is I want to know.
Arjuman will tell you. If I and Saba will comment, it will be a biased thing. Arjuman will tell you because she has been, a lot of with courses, and recently she passed her MRCPI as well. So I think her statement will be more authentic. What you say,
Yeah,
Dr.
it's better. It's better. Can you share the Dr. Arjuman?
Yes, doctor. For making a rapport with the patient, this will be a very good initiative from the candidate side to ask what you prefer to call me, or would you like to call this one? It was very pleasant for the patient too.
Okay, thank you. Thank you very much for sharing. That means I will tell, may I confirm your name and age, please? After that, I will tell, may I call you by XYZ, whatever her name, I will ask like this. Okay, thank you, ma'am. Thank you for the clearance. Thank you very much.
And Monia,
Thank
thanks
you.
for asking. Listen, whatever comes in your mind, either it is monkey, junkie question, whatever, please ask. If you
Please don't
ask,
mind, ma'am, because I was confused. Now that's why I asked.
I'm even telling you, this was very logical question, by the way. I'm asking even a monkey junkie question. Please ask and clear. We are here for you guys.
Actually, you are right. Some of the mentors are said that it's not necessary to ask again the name or in a nickname, but in the RCOG guidelines and the other available material like Lisa and all this, they are specifically mentioned this sentence. Would you like me to call this and this?
And
So
I have a chance to look at the examiner's key actually. So repetition has a marks. So this thing has marks. But I'm telling you guys that's about the examiner. So inshallah, you will when you will practice, even you will say, oh, I left time, so I should incorporate this.
yeah.
So thank you very much, Dr. Saba. It was a wonderful experience with you, and learning a lot with you. Thank you very much, audience. If you have queries and suggestions, you can drop in Telegram groups.
Okay,
Till then,
ma'am.
Thank you, Dr. Hira. Thank you.
One more
Thank you,
thing,
Dr.
ma'am.
Hira and Dr.
This
Saba.
is our Zoom class for 2 or 3 topics we can do. So is there any homework means like you will give any topic and we will present that one through the Telegram by voice message, and you can upgrade us that where are the mistakes for us. Hello.
yes, definitely. There will be 4 Telegram sessions as well, and they will be for your homework. And apart from this, on your portal, there will be study material which you can practice. And as for feedback, we will modify more as you are asking for homework. I will give you 2 SPT tasks today. Right?
Yes, Dr. Hira, this was
Thank
will
you, ma'am. Thank
give
you.
them one miscarriage and one other thing we left from the early pregnancy. Give them that SPT task. And guys,
ma'am, give us the task and give us the deadline. The 2 days or 3 days. Give us.
Yes. I was about to say this, and I will give the feedback only those who completed within these 2 days. Please.
Yeah, ma'am. Please.
That
we
will
need
be,
pressure,
that will
ma'am.
be good. Then we can do. Otherwise, we will say tomorrow.
One more thing, if you guys attend all the live session and if you present or the number of presentation, whenever who has more presentation, we will do the free mock for that candidate. But that mock will be actual exam mock.
Very nice, ma'am. And Hira, ma'am, I must admit one thing. Yesterday in the Telegram group, you have put all the early pregnancy topics, with gist, summarized topic, and also the this recalls. Ma'am, thank you very much. I was boosted, and at night. I read all these things at the night. Thank you, ma'am. Like this, if you push us and you encourage us, I think we can do it. Thank you, ma'am.
Sure.
Monia is right, Dr. Hira. You win the game in this way. completed the recalls of that module so that they don't need to worry at the end, oh, my recalls are left.
Okay, wait for the SPT task in Telegram group.
I'm leaving.
Thank you, everyone. Thank you, Dr. Saba.
शाजिया
हाँ, हेलो।
व्हाट्सएप पे आ जा। आई थिंक मैम सारे मैम चले गए, हम लोग इधर से निकल जाते हैं। व्हाट्सएप पे आ जाओ। हाँ,
ओके ओके ओके।
कैसे निकलते रे बाबा।